Yeah, thank you very much, Dr. Twinkle. So, for including me in your course, we have been doing this course for many years now. It's wonderful to see everybody. So, I'll be speaking on advances in optical biometry. Okay, right. So, we all know that biometry is the practice of applying mathematics to biology. So, broadly, biometry system, we all know they are either ultrasonic based or the optical biometer based. So A-scan ultrasound, it uses a sound wave frequency of 10 megahertz, which has accuracy of only 0.1 millimeters. So why do we use this high frequency? Because it has a minimal depth of penetration, but excellent resolution for small ocular structures, which is better for eye. But limitations of ultrasound A-scan, we all know, is that it does not depend on patient fixation like optical biometer. So whenever we are doing optical biometry, patient is fixating himself. So we are taking all measurements along visual axis. That is what we want in if we want to have a perfect axial length. Whereas in ultrasound, it's not like this. We are just measuring along this optical axis. Second problem is that ultrasound biometry, it measures till from the internal limiting membrane that is in front of the retina. But actual measurements we need from RP level, so that is what optical biometer does. So ultrasound biometer, they just measure till internal limiting membrane and take assumption that of average retinal thickness from 100 to 300 micron, and they add to it and they give the result. So we never have accurate results. So that's where these are two differences where optical biometer, we all know, scores over ultrasound A-scan, and why we should all shift to optical biometers. Then secondly, we all know that if you are using ultrasound, of course you have to go for immersion biometry. Contact is of course a big no, because indentation role always comes in when we are doing applanation biometry. So coming to can I have the pointer please? Audio visual? He's busy. Okay, so coming to the principle of optical biometry, so they're all based on, the mouse is not working. So they're all based on principle of laser interferometry. So this is the principle of pointer. This is the principle of Michelson interferometer. So what happens is there's a source of light, which when passed through a beam splitter, it divides the light into two paths. And once the light come back again, so there is a detector. So there is a detector there. So this is the source of light which gets splitted by beam splitter, and both the light travels back, and then this detector detects the length of the light which has traveled, the path which it has traveled, and then gives us the axial length. So this is the basic principle which you have learned in physics. So just to make it more understanding that what are different biometers and how the waves are used in this. So if we look at the SSOCT and SDOCT, so these are the waves which are out of phase, but they have, and also they have variable phase difference. So these kind of waves, they are used in the newer SSOCTs. So this is the spectral domain OCT, and this is the SS swept source OCT, which is optical biometer 700, which is based on. So the first biometer, optical biometer, which was there was the IOL 500. In 90s, it was launched. It was based on the principle of partial coherence interferometry. So, and it used a 780 nanometer multimodal luminescent diode. But the limitation was, till 90s to 2000, limitation was, of course, it became gold standard because it gave accurate axial length, but limitation was only optically, it was measuring axial length, ACD and lens thickness, everything it was giving based on slit scan, not optically measured. So then came Lenstar 900, which was based on optical low coherence reflectometry. So, and it used 820 nanometer superluminescent diode. So optically it was measuring all the parameters which we wanted, like axial length, CCT, ACD, and lens thickness. So that's how they developed. And K readings, they were analyzed from the anterior corneal curvature at 32 reference points which were oriented in two circles and at the 1.65 and 2.5 millimeter optical zone. So keratometry also became better, and all the parameters we were deriving, because as Dr. Twinkle mentioned, as the formulas advanced, we needed all these parameters to feed in those formulas. And these biometers, they were giving us better results. So this is the basic difference. PCI, which is optical, this biometer 500, which has a dual beam setup, and OLCR has a rotating glass cube system. This is a patented system of these biometers. So after that came AL scan, which was again based on partial coherence interferometry. So different principles were used in different instruments. Then came Aladdin, which was again based on optical low coherence interferometry. So till now, the limitations with these instruments, so axis length was taken care of, all parameters were taken care of, but limitation in these instruments were penetration in dense cataracts. So they were not able to penetrate through posterior subcapsular dense cataract or mature cataracts or like that. And they only measured anterior corneal curvature. So then came the newer generations of swept source OCTs, which we have now. We have IL Master 700, which is based on swept source OCT. So why it's called swept source? Because wavelength varies from 1035 to 1095. As I showed there in swept source, this wavelength, it varies. It does scanning at rate of 2000 scan per second. And so if we have a look at this, so these are the 2000 scans which are taken per second. It scans at 0, 30, 60, 90, 120 and 150 degree axis. So it gives an image like this. So you can see OCT right from front of the cornea to the back. You can check for the foveal fixation, whether if you see a good pit there, it means fixation is good. Then what does it have is it has a telecentric keratometry. That is, when you take a keratometry measurement, it's independent of the distance from the instrument, so that you never have unreliable readings. And it does 3-zone keratometry. At all these spots, they were taken at 1.5, inner one, 2.5 and 3.5, and 6 spots in each zone. So this is a 3-zone keratometry. And another thing which it does is it gives us the total keratometry. It measures, because it has OCT incorporated in it, so we can get the total keratometric value. And it does have the formulas which are based on total keratometry, like Barrett TK universal 2 for normal eyes, Barrett TK toric for toric IOLs, and Barrett True K with TK for post refractive surgery eyes. So as I said, and another thing which it has incorporated is the Chang varying chord, which is equivalent to angle kappa, which is angle distance between visual axis and pupillary axis. So if you see here, it gives Chang varying chord here, it gives 0.8 millimeters. So for all surgeons, they love to do trifocal and these lenses if it is less than 0.5. So it states away give these readings. So next, swept source OCT, which is I'm personally using, is a OA2000, which is manufactured by Tomy. It is also based on swept source OCT, and it has a scanning rate of 1250 scans per second, uses 1060 nanometer wavelength. It also gives all these measurements, and it has a Placido disc, which has 9 rings in it. So now Lenstar has also incorporated T-cone keratometry along with this. Then again, other biometer is Argos, which is again based on swept source OCT, and the newer one is Anterion, which is from Heidelberg. So these are the various newer biometers which are based on swept source OCT. They give better and reliable measurements as compared to the previous one, and they're able to penetrate through denser cataracts. So they increase the usability of these biometers in our Indian population at least. So to conclude, these biometers, they provide repeatable and reproducible measurements and different ocular parameters. They are effective obtaining biometric measurement in eyes with denser cataracts. And now optical biometry is of course the gold standard for measuring all ocular parameters and eyeball calculations. Thank you very much. Okay. Thank you.
So, Dr. Harshul, what is your choice?
So personally, I've been using OA2000
Yes,
Swapsode based OCT for last 10 years now. That was a,
So, if
and
you
it
have
has
to
very
change,
good penetration.
if you have to change your optical biometer, what would be your next choice?
No, I would not like to change because this has all the features which are required. No, it has it is based on Swapsode OCT. It has amazing penetration in denser cataracts.
And do you think Argos has a huge advantage over the previous ones?
No, I think I place 700, Argos, Anterion, OA2000. They all are same. They give the, and of course 700 has advantage that it gives true K readings also, which this doesn't give.
Yes.
But there is studies have also shown that clinically and practically
Yeah.
results, nothing much to gain if you use even the TK formulas compared to the normal universal Barrett 2 formulas.
I think that's a very nice take-home message. Thank you.
I am also using the OA2000, but are you happy with the curtometry which OA2000 is giving you?
Yeah, of course.